To kick us off, I wanted to start with a bit of context and I guess a bit of history. So, Maxine, you raised the point before that e-health, digital health, all of these things are now health. But 5 years ago, that wasn't anywhere near the case. So I wanted to get everyone's views really on what's been the driver of innovation in health and what has actually gotten us to this point, so we can now have discussions like this.
So I think that what was different 5, 6, 7 years ago was that if you wanted to innovate in healthcare, the only kind of real way to do that was to start a clinical trial and to build a drug. And obviously, none of us have, well, some of us do, but most of us don't have, a couple of $1 billion in our pocket. Whereas because technology and the skills around it have become so much cheaper, you can build a wireframe of an app, basically for free. There are developers all over the world that can help you do that unless you're a developer yourself. So the kind of activation energy and the cost needed to create a solution has gone onto a completely different platform, which I think has become so much cheaper, it's become so much more accessible. So yeah, everyone and their dog can build an app. I think as a result, you probably have less good solutions, but we have many, many more. So I think a wider pool has probably been a good thing for the whole system.
Hi everybody, I'm Manoj, working at IBM Research Australia. As you can see, I used to be an academic and also worked for the US government Centers for Disease Control. So now I'm trying this third option of working for a mega corporation like IBM and trying to do innovation within the context of a mega corporation. So speaking to that question, yeah, I mean, within a company like IBM or within a big company like Google, or Facebook, all of these companies are moving towards innovation in health. They've all identified health. IBM has done it in a huge way and has oriented the corporation towards, a large part of the corporation towards health. It is very different within a big corporation. You can rely upon the contacts that you have with governments around the world or with other companies to create solutions that are based upon years of research and not necessarily doing it in a very quick manner, but we are adopting those practices as well. So I think the advantages from a big corporation point of view are depth, years of work and research that could be deployed in an accessible way, potentially to governments and other big corporations.
My clinical work is as a GP, and I think in high income settings there's a massive financial drive that really is incentivizing this groundswell of technology, particularly in consumer focused products and devices and better monitoring, and there's an enormous willingness to pay, and we really see that generate a whole lot of new technologies which in turn generate all of this kind of sequential data. So I think a lot of this groundswell is both obviously technological capacity to generate the amount of data, but also a massive business interest in achieving those outcomes. And I think one of the issues that you were talking about, and that's kind of relevant to the themes this weekend, what does that mean for the non-willingness to pay community? So for developing settings, for settings of inequality, where my feeling is a lot of the drivers are for really amazing monitoring of insulin and blood sugars, but in places where we're just trying to count the number of people who live somewhere and what they die from, there's not so much a willingness to pay or necessarily a robust understanding of the value of data as a sort of concept. So I think the drivers are a little bit disconnected from the people who've got the capacity to benefit the most.
Well, so I think the digital thing very much is like a gold rush. So, as you always get with gold rushes, there's lots of people doing stuff which is completely ludicrous and some stuff which is okay and some stuff which might be reasonable in the context of an ever-emerging, evolving regulatory environment. And I guess as a consequence of all of that, it's a very interesting world to be in. There's lots of interesting opportunities to be had. And I think bringing kind of cold, rational thinking is a valuable way of looking at it. I think when it comes to the resource-rich stuff, I have to say the conversations I've quite enjoyed having are usually with venture capitalists, because they tend to, have an interest in funding things that people will pay for and things that people will pay for on the whole, have a business model that means they can actually get built, scaled, and used. and it's very different in the environment where there's no money. But yeah, I think I would say that there's lots of opportunity, and having ideas at this stage in different stages in careers is a fun place to be.
I mean, the reality is there's no quick money in health. So for a lot of VCs, I think they burn time and effort and all these sorts of things. So I wanted to get everyone's thoughts on the kind of startup environment and actually the pitfalls and challenges of our approaches, and also look at the differences between these environments in developing and developed nations.
I guess I can speak to I personally have done a lot of reading and listening to people and podcasts and about the startup environment within health. Again, it's very different within IBM. It's very different in a university and in a government context. I definitely found within university context in Australia, we're quite behind the sense of it that you get in a place like the US, where every university has a technology sort of translational office and a sort of a startup fund almost, and I think that is beginning to happen here in Australia. Governments also are somewhat behind, and actually, so my personal sort of kind of story or trajectory into a place like IBM was very much that I wanted to. I'm from a maths and physics kind of computer science background, very nerdy background, and I felt that there would be a very easy kind of translation of those skills into the developing country context. So I would just basically program up my solutions, go out to Rwanda, and distribute them, and everyone would use them, and it doesn't happen that way. And part of the reason is that governments and other big institutions in developed countries aren't equipped themselves to use those solutions. So I've sort of gotten stuck, not stuck in a good way, in the developed country context, so to try to upskill people in the developed country context. From the point of view of startup, venture capital, etc., funding in the developed world versus the developing world, it's really difficult. So certainly the social enterprise scene is the main way in which funding is going, I think, to developing country contexts. It's really unclear in the developed world where the money is going to come from, the business, sort of the big business idea, the equivalent of Google, if you like, in the health sector in the developed world. So that's something that we're still sort of making lots of bets on, and something that Alexander's talked about a moment ago. There's lots of crazy stuff going on, but there's lots of good stuff going on too.
So there's lots of, in the UK, there's a very sort of unhappy, quite depressed, quite disheartened bunch of people, and they are health technology entrepreneurs, because it's a kind of well-known problem in the UK that no health tech startup can get into the NHS. The NHS is, our national health system. It's in charge of over 60 million people. Obviously, there's not one door to access it. There's thousands of doors. The NHS has one brand. It's basically thousands of organisations. To navigate that maze, the kind of the labyrinthine public sector, is impossible for your sort of dinky little health tech startup that's trying to, transform healthcare in the UK. And so these startups spend a lot of time bashing at the doors of all the various commissioning groups, of all the various different doctors, trying every route possible. So there's a degree to which the time and effort that takes to go for those discussions to get those contracts, is different to, say, in developing countries. It's not my area of expertise. We have a number of entrepreneurs on the network who say, well, you don't have to deal with legacy systems. Interoperability isn't a problem because there's no system to have an interoperability discussion with. And so there's a leapfrogging certainly when it comes to healthcare, and that can be seen with every single piece of technology. But from a kind of developing countries perspective, there's sort of two interesting examples I think just shows the amount of money just being thrown at the problem in a way that's not particularly helpful. So one, I was speaking to investors who said 10 years ago, the biggest predictor of whether you were going to be successfully invested in was the frequency of the words genomics in your slide deck. Now, exactly the same model was applied, and now it's the frequency at which AI appeared in your slide deck. And so there's a degree to which, if you say AI in healthcare, you're like, fund it, it's going to be amazing. And I think that's a kind of unhelpful, slightly sloppy way that you're now seeing lots of healthcare startups coming up. The second is something that really struck me and Alexander. there was a company that closed a massive round in the UK, and a week later, the CQC, which is one of the regulatory bodies in the UK, said that they found the company to be unethical, and they found that they were prescribing many more antipsychotics, that it was not safe for patients. So a regulator saying it was unethical and unsafe, a week before, had announced a massive round. And you see these posters all over the tube saying, I'm not going to name the company, but saying, go use this company, use this company. And so I think there's certainly a danger when it comes to health tech startups, the direct-to-consumer marketing, the fact that the regulators aren't sure how to interact with them, and that there's tons of money going into it, means that there's a bit of a kind of confusing and potentially unhealthy dynamic that's being brought up.
I was at the Pacific Island Health Ministers meeting last week, and it was like all of the 22 vulnerable developing Pacific Island ministers sitting around a table in matching shirts. And one of the sessions was on health information systems, so like just the medical records stuff. And basically they each went round and told a version of the same story, which was we knew we needed something more than paper records. Then we started mailing USBs to each other, and that wasn't really working between the islands. So then we tried to procure a software program, and we bought this one that sounded really good because somebody came from somewhere and promised us the answer, and there wasn't in-house capacity in the country with 10,000 or 30,000 people to make an assessment of how well that technology was going to fit. There wasn't a lot of thought about the staff who were going to be using those platforms. Then it turned out that in lots of places all the internet came through an undersea cable that had been hit by an earthquake, and so country after country after country said, we know we need better information technology, we need the data, we want to buy it. The World Bank were there, Asian Development Bank were both there saying, we want to support you to buy it. But there were these massive procurement problems where developing countries who were really remote, really vulnerable, just didn't have the expertise or the support to make good decisions and to be able to maintain a system. So I think there's some really cool stuff happening in that space and other bigger, sexier spaces. But for the people who need it most, the capacity to use it, to procure wisely, to maintain those things and to get the biggest value is still a massive gap, and it's not quite as sexy to fund as the app or the software or the thing, but the other context is critically important.
I think in some ways I think there's some sort of analogy, what wasn't alive in the 50s, but before those randomized controlled trials and then eventually guidelines, etc. Those people running around sort of selling snake oil to an extent, and it feels a little bit like that at the moment. I think it's difficult because in general practice in the UK, we get lots of startups who come and tell us how difficult it is to get into the UK health system, and then you say to them, well, give me some evidence that what you do is going to be beneficial to my patients and also somehow make my working life easier, hopefully, and on the whole the evidence doesn't exist. And I suppose it's a difficult balance, because on the one hand one wants to create an environment in which innovation is supported, and on the other hand everybody's busy and we don't have lots of time to sort of tinker around with stuff which doesn't yet work, and moreover it would be unethical if it was demonstrated to do some harm. And so I think the emerging models for people demonstrating some form of return on investment in digital have not really come to fruition, and partly I think the reason why that's different from drugs is twofold. One, they're complex interventions, so they don't just do one thing. It's not just drug versus placebo, it's a number of different types of interventions often packaged in a single piece of software or technology. And two, that they evolve, whereas in drug trials what happens is you do your biomedical research, you make a drug, the drug is there, you do a trial that against placebo. In technology products, Google's changing the colors all the time, and as a consequence your systems are evolving, so the evidence that existed before doesn't necessarily bear fruit in the future. So the fact they're complex and evolving, and just to double down on the evolution point, I think that stick artificial intelligence into that, the system is also learning. So it not only is evolving because the people are sitting hard coding differences, the machine itself is improving. And I don't think there's at the moment a good way of demonstrating in robust ways that there is a good return on investment with that type of technology in the healthcare setting. I can't think of any whiz-bang New England Journal of Medicine trials. And I almost think maybe a good premise would be to start from what does the New England Journal of Medicine trial look like, and then design a piece of technology around that, because that's the kind of burden of proof people are going to want at a state level in order to adopt new technologies like this, I think.
So I wanted to take the first question from the app, and I apologise for reading for the screen. It is a very good question, so I'd like to do it justice. There's some amazing new technology for personal health monitoring, your Fitbits and so on, tech for diabetes, and all these things that generate amazing data sets. Now, simultaneously, there's growing awareness of privacy concerns with the big health data being sold onto third parties, and concern about who has access to it and how it's being used, for example, to raise healthcare premiums for individuals with poor health metrics. Now, how can we ensure that our enthusiasm for big data does not erode the human right of privacy? I'm going to hand that one to you.
Oh my God. The human right for privacy and enthusiasm with for big data. Yeah, I mean that's a time-honoured question. I think everyone's quite concerned with this. Well, most people are quite concerned with this. And gosh, something that Maxine was saying earlier about, those populations who are kind of ignored in a sense from the data that we're gathering. And part of, just to respond to that, and I'm sure you know, and probably many of you in the room know too, that part of the technology that is being developed by companies and like Google and IBM and universities is how to deal with those blind spots, like how to adjust the data sets that you have, or how to adjust the analysis of the data sets that you have to acknowledge those blind spots in the data, to sort of create more of an equitable distribution of the analysis that you do. But yeah, that is a big problem, which I'm going to duck at this point.
So I think I sort of have two responses to that. It's which one trumps, patient safety or patient privacy? So if you are in an ambulance hurtling towards near death, someone's not going to say, do you have consent for us to do anything? It really is like, save this person's life. Obviously, that's quite a sort of divisive, maybe slightly dramatic example. But the point is that in the hierarchy of importance, I think most of us would agree that patient safety should trump things. Obviously, it's a balance in terms of how the privacy interacts. But I often think when people say, oh, what are the risks of electronic health records? It could get hacked. And I had a very sort of frustrating conversation with my GP saying, can you just email me my electronic health record? And they said, no, we can't because of patient privacy. I said, well, I'm the patient, so you just email me my record. They said, no, we can only print it out. And I said, well, okay, well, what's the problem with being on email? And they said, well, it could get hacked. And I said, well, what if I leave my printout on the bus? What's the difference? So I do think that by ignoring all the data we have available that's sitting in electronic form, we're basically saying there is evidence that of a system that we know is happening. This information of what's going on in your hospital, we can see it there. We're going to ignore it because of privacy. I find that immensely unethical. I'm not saying that therefore we should just open up everything, but you've got to look at what's the alternative. The alternative is not using that information. You're saying no to evidence that you could be using. So I do think that's a sort of fine line. The second thing is that I'm sort of championing quite a lot is what is health data. So we're very worried about our healthcare information being sold to insurance companies. Yet if anyone's had an STD, I'm not saying I have, but think about the scenario is that you type into Google spots on my bits or whatever. It says these are potentially what you have. You say where's my nearest STD clinic? Here are the opening times. It doesn't take a data scientist to work out you probably have an STD according to what you've Google searched. Yet, people are very worried about the fact, oh God, what if someone can see I've got an STD in my electronic health record? So you've got to start to realise where you're feeding health information. It's often sitting in Google, it's often sitting in your Facebook, in your Instagram, in your Twitter. And actually, when we worry about health data, it really is the kind of non-health data which is probably most strongly predictive of you being ill. And so I do think that we have a sort of slightly misguided view of what is health and what is non-health data, and therefore who holds that. So to Manoj's point, I think actually the real concern is the fact that Google is a real holder of your health data, not your electronic health record supplier.
Yeah, that's very similar to my responses. I think there's a real distinction between the stuff that you and your doctor talk about in a closed room with the door shut and what we write down, and all the other stuff, which is a far better predictor of what your insurance premium should be, like the suburb you live in and what your postcode is and what cigarettes you bought and how far you walk to work and where the park is. There's so many other determinants and so many better ways or more powerful ways to get data about what your health outcomes are going to be than that conversation. And I suppose as a clinician, I feel like that conversation's a little bit sacrosanct, and the way we record and share that is different and special in some subtle ways. But the bigger question is not the health stuff, it's the indirect, the social determinants of health that are really where the money is, literally and metaphorically, in terms of your privacy and impact on commercial sensitivities and things.
No, okay. So I might just grab the mic back. Yeah. So another question from Twitter, sort of leading on from that, is our increased the health technology side of things, is that actually feeding the anxiety epidemic in high-income countries? You had a nod there.
Oh yeah, I think it's everybody at least risk of diabetes who comes in to talk about how many steps they should be doing. There is an absolute inverse of care applying, where the most worried well are the people who turn up with their app, and it is the least worried unwell who I think are least engaged. And I think mixing that up is obviously a big, interesting challenge. But in terms of the people who walk in the door and sit down and whip out their phone, it's the people I'm least worried about.
Right, I like the thought of the unworried unwell. The unworried well. What do we want to be? I want to be unworried well.
You want to be unworried and well.
Yeah, that's a good category. Yeah, I mean, I find it different to disentangle the extent to which that's because of people using technology. I don't know. So it's easy to think when you sit in general practice that existential health is just at an all-time low, and
this is painfully true.
Yeah, and it's difficult to know whether or not that's true, I think. And one often feels both that the social determinants are bigger, but also that the determinants of somebody's well-being sit well outside of the clinic. The extent to which technology, for me, health technology, whether or not someone's monitoring their steps is one form of anxiety, but, there's some trials that show that, going on Instagram, Facebook, Twitter, all substantively reduce your well-being. So, whilst the rhetoric is that, those are companies connecting and changing the world, the substantive aggregate footprint on the well-being of the planet of Facebook, if it is genuinely reducing people's well-being and it has 2 billion people on its platform, for me is in a sense a far bigger threat to existential well-being than a few people that come in having said that they've not done quite enough steps yet. So the broader impact of technologies, Steve Jobs fundamentally, when they were making technology, they didn't have to prove that it did anyone any good. They just had to prove that people want it. Whereas in healthcare, you have to do a trial that says people don't necessarily always want it, but it does them some good. And I think there's probably, for me, it's a relatively second order problem, health technology and well-being. And it feels like there's much bigger threats potentially from technology to well-being, which to me is like a super interesting question, because if it's true that this ever escalating sense of technological progress, much lauded by the Californians, is in some ways or in some facets contributing to a reduction in well-being, that seems like a funny form of progress in my mind.
Yeah, that's a really interesting point. Yeah, we do hear increasingly that time spent online, just actually screen time, actually is reducing our well-being, and so and increasing our anxiety, and so yeah, that's a terrific point. I mean, health technology is a really broad term, and something that I would refer back to. Elia said this yesterday, and I think this was mentioned by you today too, Alexandra, about health systems, broadly speaking, are a health technology too. Having a good project manager in your organisation, that's a kind of health technology too, and so that wouldn't necessarily increase anxiety. We're talking about a very specific aspect of this relating to social media primarily.
Anything else? So sort of picking up on a point that you made before about the prevalence of artificial intelligence and that kind of thing in pictures, it strikes me now that everyone, particularly investors, have this kind of techno-boner for artificial intelligence and machine learning and all these things. But if you actually go and speak to people, they're quite fearful of this, because there is a view in hospitals and healthcare systems that technology might actually replace the worker. What are your views on the role of the individual in the healthcare system as we go through this kind of technology revolution?
The healthcare is, I think, a very hierarchical kind of workforce. It takes a long time to train you up. It's very expensive to train you up. There's a very clear hierarchy to who you can and can't report to, and I think that's probably a healthy thing. You don't want sort of a junior doctor just innovating at the surgical table. So I think that those things do make it a bit of a harder workforce to disrupt, dismantle, replace for jobs, because it is slightly protected by lots of infrastructure, lots of institutions, lots of tradition. I would say lots of social class as well, certainly in the UK. So I think that though you might have technology coming from lots of different angles saying, well, actually, this algorithm could do your job better, I think it's going to actually be quite difficult to penetrate because of those, I guess, cultural factors. Radiology is a very good example. There's so many papers being published now to show algorithms are better at picking up different tumours, different cancers than your average radiologist. We're now looking at sort of 95, 99% sensitivity and specificity at 1,000 times the speed. It's very hard to make the case that an algorithm should not replace a radiologist at that point. So I think that when you're comparing about those sorts of metrics, just sensitivity and specificity, i.e. the number of correct diagnosis, which is a yes, and when that's better than a doctor, and even in that face of that evidence, jobs aren't being replaced, you've got to sort of start to question where you're putting your resources. But the main thing is, and this is something that happened, we talk about a lot in these panels, is healthcare is about care, it's about the touching, it's about basically nurses are completely the future of healthcare, diagnosticians are not. An algorithm can compute a multivariate model, which is the human body, far better than any doctor. An algorithm can read the latest papers, look at every single drug interaction, compute your medical history in a snapshot. A doctor has fundamentally a sort of average brain, just like most human beings, compared to an algorithm that can do such a complex multivariate model. So if we look at it like that, and we can see and say, well, actually the outcomes would be so much better with an algorithm, it makes it very difficult, I think, to see the value of a diagnostician. But then you start to really see the value of nurses and primary care and the more kind of human-to-human interactions, I think.
Again, I'd probably go to the kind of return on investment thing. Like, as soon as someone could show that they have a good case for replacing a person, augmenting, I think, first and then replacing, and that case looks really robust, I do think the establishment probably would buy into it, but people on the whole, there's I think a slight mismatch in the frustration of the high rhetoric AI companies and the conversations with the clinicians. Fundamentally, they're not going to replace, I'm not going to lose my job, hopefully, maybe for other reasons, because of an algorithm next week. So I don't think there's really the notion that clinicians sit there feeling this sense of threat. I think there's occasionally ego, a machine can't do something as complicated as we can. But I don't think there's any real sense that your job's not going to be there because of some machine in any time soon. And in actual fact, I think if you were able to go and show, look, this thing really clearly, in all appropriate cases, deployed in this environment, which is exactly the same way that the clinician would have previously done it, or it replaces a certain element of the value chain, my feeling would be that probably the establishment would not be averse to listening to that story. I do think there is a slight challenge, which we also talked about in our Gold Mountain conversation. So much education about Australia in that little excerpt. But we were talking about the guilds of the royal colleges and the institutions that do the regulation. I definitely saw, I'm involved in running the graduate entry medicine teaching program at one of the Oxford colleges, and they still learn all this like super niche stuff about listening to all sorts of random things that Osler discovered in whatever century, and in reality they're just like complete nonsense, but you do it because it's part of the ancestry of our profession. And so I suspect there is definitely room for people to think slightly differently about how all of that happens, and I suspect it's difficult to disrupt, unlike the black cab industry, I guess, is difficult enough to disrupt, and they, I guess they exert their power by blocking the streets. Doctors have always got this thing that they can wave over people that is nobody else can say that they're a doctor, and nobody else can, with exceptions, sign a prescription. And those two things protected in statute mean that it's more difficult for someone in a warehouse in some trendy industrial place in Fitzroy to come and disrupt them. And so I think, there are problems with the institutions. They do need probably new types of leadership, thoughts about how the future should look. But I also think if people can prove that stuff genuinely is beneficial and they can demonstrate that in an elegant story, I think people will start to appreciate it. So narrowing the mismatch between what is rhetoric and what is substance, I think, is part of where the solution lies for that.
Yeah, look, I think the blue sky thinking maybe would be to take some of the ever expanding, terrifying amount of science in medicine and move that into a computer or into a sort of an AI platform, or to have a more accessible way of accessing that information as it amplifies exponentially. But I think the thing that's irreplaceable is the relationship and the sacrosanct closing the door, chatting, and the lived anxiety of responding to screen time and the relationship, soft touch stuff. And that's in some ways what we're not always training our clinicians and doctors and nurses and the sort of whole healthcare system to do particularly well, because it gets crowded out of the curriculum by looking for rare clinical signs and interpreting these increasingly massive amounts of data and science about how we do medicine and get the best outcomes and the best oncology approaches and the best whatever. So if we could maybe use this opportunity to humanize medicine and caregiving and illness and some of those human experiences, and think about social determinants, and maybe leave some of the hard science that we're never really going to wrap our arms around sufficiently well, or as well as a computer, to somebody else. Perhaps that's a way of getting a win in both worlds.
Yeah, from the perspective of a company that does work a lot and has pushed the idea of Watson, of including Watson in various domains, particularly in medical imaging and diagnostics, which is what we were talking about a moment ago. Yeah, I mean, I would agree that augmentation, human intelligence augmentation, or the augmentation of the intelligence of a doctor is very likely to happen at some point very soon, and then possibly for certain roles within the medical profession, replacement too. But then we are talking about individual level diagnostics at this point, and I think that then we will be liberated in a way to talk about group level population ideas, which are still at the frontier of what we understand. A lot of what happened with the Ebola crisis in West Africa wasn't necessarily due to the fact that we didn't know what to do once we encountered someone with Ebola. It was the human organizational aspects and the cultural aspects of what was going on in West Africa. And that applied not only to West Africa, but how would the CDC and the WHO and the UN who were coming in, and Médecins Sans Frontières who were coming into West Africa, what would they do and how would they push their message? And we saw all sorts of tragedies happen when those organizations came into contact with culturally different groups in those countries. So I think individual level diagnostics, that sort of thing, we're gonna come to a kind of a new frontier. But I think that will liberate us to think about complex systems issues like population health.
It's a thing people clearly it's very of the moment to try to think it through and work to understand it. I think just as a principle, designing first with evidence in mind, which many startups don't historically do. You start with proving the customer is delighted, in a sense. And I think that simple thinking as a way of a startup designing technology is probably the most important thing. Second thing is, in our healthcare system, again, there's in Uber there's the taxis and there's the people using the taxis. In healthcare there's the kind of the doctor, the commissioner, and the landscape of stakeholders is difficult. So mapping out who the customer is quite difficult. So I think if you match demonstration of evidence, we did this exercise is to kind of give take analysis within the system, who's getting what and who's giving what, and how do all of the people align in that system. And I think that includes for the regulator a level of evidence. If you line up the stakeholders' interests and you include for the regulator the evidence they need, to some extent the clinician, I think that's probably a good start point from the perspective of the startup. From the perspective of the regulator, I don't know the answer. The sort of cliched thing to say would be some form of adaptive, evolving trial structure step wedge type design where you kind of have multiple different arms within something that enables the different interventions to emerge across time. Those have existed for a while in various sort of personalized medicine contexts and haven't quite nailed the problem, so I suspect that's not exactly the end of the discussion. I think I would try to maintain interest by saying I think that's a hugely pressing problem of the moment, and it's one that nobody's really worked out how to solve, so there's definitely a kind of intellectual architecture to be developed. And there's no reason it wouldn't be an interesting thing for people in this room to think about and work on.
There are tens or maybe hundreds of roundtables, committees running at any one time in the UK around how can we regulate digital technologies. I mean, the amount of roundtables I've been invited to, that every organisation is trying to do their own multidisciplinary, multi-stakeholder discussion around this. So everyone's having the discussion, but there isn't yet to kind of have an outcome.
Yeah, nothing's come out of the wash. I couldn't say, somebody said something that was really clarifying.
There's definitely, so the MHRA has, in the UK, has definitely said post-Brexit, we want to see if we can be the leaders, given this flexibility, if we can start to be the leaders in the kind of AI health regulation. So something they've said, so maybe there's a degree to which they're seeing this as a silver lining for a bit more kind of regulatory freedom, but again.
We're going to become the Grand Cayman of AI, maybe.
Do you have any thoughts? Okay, well in that case, let's actually look at those consumers and the people at the other end of the technology. We've seen how there's obviously a growing need and a value of technology in healthcare, but how can we also increase the level of consumer tech literacy so they can actually make the most of this?
But it goes towards how do you increase the scientific literacy of the population, and I don't know. I've struggled with this for a long time, actually. I've lectured at universities. I've tried to teach, epidemic intelligence service officers who are medically trained at CDC about mathematics and epidemic dynamics and things like that. So I've tried multiple different approaches, and one of those approaches is to sort of popularize what you're doing and make it accessible in terms of make it very pictorial and very kind of digestible. But I've sort of come away after all these years of thinking that maybe that isn't so much the best approach, because when you watch Nova in the US or Catalyst here or BBC Horizon TV show in the UK, you sort of see the same things being trotted out all of the time, the same sort of images of the population walking down the street, kind of blurry, and I'm not sure how much information it really conveys. So I like the movement that we're seeing right now, where you have it's slightly overused, the hackathon idea, where you come to a room and you kind of get together with people, and it's more broad now than just software development, where you can really come up with a product, some sort of presentation business plan, maybe a piece of software, maybe a widget after a couple of days of working intensely with a group of people. But it's not a bad idea, really. It's not a bad way of doing this, to actually produce something with people. And the software engineering basis for this is pretty strong. That you do actually end up with several hundred lines of code that does something after a few days, and you could perhaps potentially start off that 2-day period without really knowing anything about how to do the coding or how to do the development of that technology. So I think actually that getting your hands dirty, while it can be a bit difficult and a bit confronting for a lot of people, is actually probably quite a good way of increasing literacy. But it's not a method that scales very easily. You can't just put it on a TV set and show it to millions of people at one time. So it's difficult to reconcile those two things.
I think this might be slightly controversial given Manoj sitting here, but I think IBM Watson is a good example of maybe how not to do it, but what was well intentioned. So IBM Watson, put your hand up if you're familiar with IBM Watson as a brand. So that's quite a lot, given the fact that it's an AI thing, and none of us are AI specialists. IBM Watson is an unbelievably well recognised and powerful brand, and I think IBM's been very open about it. I'm sort of not having eye contact with Manoj now. IBM's actually been very open about the fact that they've slightly over marketed it. I've got lots of colleagues in the UK who have been actually very open about the fact that they didn't really understand what AI was. There was a degree of personification, anthropomorphization of IBM Watson. So they were like, yeah, you just call up Watson and IBM Watson comes and sorts out your problem. You know, and IBM Watson is a platform. You have to train it. You have to work with your data structures. It's a process, and it's a partnership with IBM. But they were so good at marketing this IBM Watson persona that lots of its customers have now been quite, disgruntled. And I think that was a kind of information flow problem. So that's an example of if you make something so accessible and so easy to understand that it goes too far and becomes misunderstood. You've got to kind of balance it how you describe complex systems like AI. And I think the IBM Watson is a very good example of good marketing but mismanaged expectations.
No, I would agree with that. Actually, it was it was somewhat premature. It was the sort of AI benchmark of its day. Watson winning Jeopardy in the United States was the benchmark of its. Was the AlphaGo of its day. Was the sort of the burgeoning self-driving car sort of revolution of its day. To push that, I mean, that was actually driven. I've sort of subsequently found out this isn't something that is that openly discussed, So, but I've had to sort of do some digging of my own. But that was actually moving Watson from essentially a TV game show playing a piece of software to very soon thereafter, within 6 months, talking about this on US kind of television interview shows. About that this was going to be used for cancer diagnosis and to help people improve their chances with cancer prognosis, was something that was actually driven by, I think it was the MD Anderson Cancer Center in the US. So this was actually, IBM was approached by cancer centers within the United States to push this idea forward, and it was such an attractive idea at the time. So going back in context, you can see why IBM we all became a bit too over enthusiastic about this, and didn't necessarily do the core work. And I think that is changing now. It's changing within IBM. It's changing also. I think the other companies have learned the lesson of this too. I think Google has been sort of an exemplar at this, creating incredible breakthroughs that are just almost breathtaking. How does the AI now outperform humans at 58 out of 59 Atari games from the 1980s? How does it do AlphaGo, which we thought was 10 years away? Chess, we thought chess was the AI frontier, and it was, and then suddenly it was surpassed, and it's no longer the frontier. It routinely beats humans. So we pushed a little bit too hard. It's easy to see why that happened in context, but I think that there is a course correction happening.
Look, in terms of how do we make technology more acceptable to people, consumers, patients, I sort of hesitate to use the word, but I think it is the gamification side of things that people respond to. The Australian government's got this app called My Quit Buddy, which I have on my phone, and it says I'm a pack-a-day smoker, and then when I talk to someone about smoking cessation, I whip out my phone and hope no notifications come through inappropriately, and I show the patient, and we talk about how it calculates the amount of money you've saved, the amount of tar you've avoided. It's got a running tally in it. It's got all these distraction things, so if you've got a craving, you can do like a small game that lasts for 30 seconds. You can upload voice memos from your children asking you not to smoke. It's got a lot of concerning features on it. So you sit down with the patient and you set it up once and you say, okay, how much do you smoke and how much does each packet of cigarettes cost you and what are your goals at the end of the year and stuff. And look, it definitely works better for people who already have a smartphone and are sort of literate, and it's still missing people who share a burner phone in a remote community. But it seems to work for a proportion of the population. And if we could move some of those behaviour change things, there's some work being done in Indigenous communities on Facebook apps, because in remote communities often phones and SIMs get lost or passed around or they're shared, but Facebook accounts seem to be a bit more special or a bit more individualised. So there's a bit of work trying to build some of that gamification health stuff into Facebook as opposed to phone-based, and a bit of evidence for that working. So I think it's probably about word of mouth recommendation, like you go to your GP and they show you how to work the app, or you do it with your community health worker, which would be a much better solution. And then maybe we can get some of these things, some health technologies, to really useful places. I don't think there's a one-hit answer though.
We've gone well over time, but look, there are quite a few people who had their hands up. We apologise for not getting through all of your questions. Everyone is around for the rest of the day or parts thereof, and you've got the workshops coming up. Please go and have a chat to our speakers, but I'd like to thank everyone again.